Um, It is abdominal trauma, especially the solid organ injury. It is one of the leading cause of significant morbidity and mortality following injury. And usually, the variety, especially the blunt abdominal trauma, is challenging to identify what is the injury inside, what is the area that has been injured, and many injuries they manifest during the initial assessment and treatment. Early identification is essential during the initial assessment and treatment phase. Now, what is the initial assessment and resuscitation? We call it the primary survey and resuscitation, just like we discussed yesterday. The ATLS, the Advanced Trauma Life Support. We will identify and treat the life-threatening injuries at the same time while we are looking the ABC of the patient. So it includes the A, B, C, D, and E. Airway with the cervical spine control. We assess the airway, and if there is any difficulty in breathing, if there is any uh, abnormal breath sounds or abnormal sounds during breathing, you have to look for the airway obstruction and you have to manage it. So you will check for the airway and you will control it. You will check for the breathing and you will manage it. You will check for the circulation and you will manage it in the form of IV fluids, starting the IV fluids, um, pressing the visible bleeding, the external visible bleeding, and take the blood for investigation as well as for grouping and cross matching, and starting the IV resuscitation with wide bore cannulas, especially in cases of external bleeding. Now, we do abdominal assessment by checking the vital signs and doing the physical examination. Usually, the site of impact is very important. The site of impact can be, it is usually visible in the form of some bruises over the abdomen, or some areas of specific seat belt sign, or some area of impaction, or it could be because of some penetrating injury like a firearm injury, or firearm or uh, stab wound. Investigational studies are that we use, especially in the setting of trauma. It is the ultrasound, which we call as FAST, or the POCUS scan. FAST is focused abdominal sonography for trauma, and it is one of the best modality, especially in cases of unstable patients, to identify internal bleeding or intra-abdominal bleeding. Then we have DPL, the diagnostic peritoneal lavage. If FAST is not available, DPL can also be used, and it is also very good in picking up bleeding intra-abdominally. Then CT abdomen and pelvis, but for CT abdomen and pelvis, the patient should be in stable condition, because it needs proper preparation. It needs proper care of the patient. So if a patient is unstable, he is not maintaining his vitals, better to not to let him undergo CT scan. Instead, go for, if need, go for exploration of the patient. Now, focused abdominal sonography for trauma, or the FAST scan. It was first used in 1996. It is rapid. It is actually portable ultrasound, so it is very rapid. Just on the spot, you can go for this, and sometimes it detects as little as 100 ml of blood, and it's very cost effective in picking up hemoperitoneum. We usually use four views: the pericardiac view to look for the pericardial, if you will, pericardial trauma secondary to injuries. Then we use the perihepatic view, in which we look for collections around, or lacerations or problems within the liver, as well as the collections around it. Then we have the perisplanchnic view, in which we visualize the spleen area and the surroundings of spleen. And then we have the peripelvic view, in which we view the peripelvic space and look for any collection in that area. The problem with the FAST is it is user dependent, and this is the inherent limitation of any ultrasound. The user is good, he can pick and can be very effective in identifying the problem. But if the user is not very technically not very sound, then the things can be missed. It is very useful in unstable patient. That is very important. The best investigation for a patient who is unstable, who is not maintaining his vital, is using the fast scan. Just give me a 2-minute break and I will rejoin after Azan, inshallah. No. Okay. So we use different views, and this you all can see the screen, or there is some box in front of it. Screen is clear? Screen is clear, or there is some problem in
No, doctor, it's clear.
Okay. So
but there is just a box is appearing. Please move this window away from the shared application.
Yes, it is clear.
what is appearing?
Nothing appearing, nothing.
A small box wrote on it, please.
Box.
Okay, it just disappeared. Just
okay. It's coming and going. I don't know why. Okay, let's see. I will make it a little down so that what is it? I think it is because of this. Okay, let's move on. Leave it. Okay. So fast scan. There is another scan, focus scan we use in urodental system. That is specific. That is again the same trauma scan. The name is point of. Let's call focus point of consideration scan of specifically for the urodental system. So we use fast scan in abdominal injuries or abdominal trauma, and it has a sensitivity of about 86 to 99%. But this sensitivity of fast is decreased in cases of penetrating trauma. Uh, uh, in penetrating trauma, sorry, sensitivity is this, but specificity is decreased in cases of penetrating trauma, because in penetrating trauma, there may be injuries related to gut perforation or posterior abdominal wall injuries, and these injuries may sometime they may be sometime missed in fast scan. So you have to be careful when you are dealing with the cases of penetrating injuries. In penetrating injuries, fast may not be very specific, but for blunt trauma, it is sensitive as well as specific. Now, what is DPL? DPL is diagnostic peritoneal lavage. We insert a cannula in the abdomen, inside the abdomen, and then we infuse fluid, and then we take out the fluid after washing that abdomen. And if the fluid that comes out is dull or it is not transparent, it is a sign that there is some perforation or hemorrhage inside the abdomen. Now, CT scan, it is the gold standard for abdominal trauma, especially for blunt abdominal trauma. But the thing is, patient should be hemodynamically stable. If the patient is unstable, CT scan cannot be performed. It gives excellent imaging of the solid organs, especially the liver and the spleen, and it determines the source and amount of bleeding, especially in the angio phase of the CT scan. It reveals associated injuries like injuries of the pancreas or the genitourinary. But the problem with the CT scan is that it is poor for hollow viscous injury, for gut perforations. If there is an associated gut perforation, it can be missed with CT scan. So can anyone tell if CT cannot tell us about the hollow viscous injury, then what will be the best investigation for hollow viscous injuries? Best investigation for hollow viscous injuries. Any idea? Give any idea, or if you have anything in your mind. What is the best investigation for hollow viscous injuries or injuries to the gut? Better speak it up, because if I open the chat.
Perforated peritonitis, دكتورة. Perforated peritonitis.
I am saying what is the best diagnostic modality for perforation of the gut secondary to trauma? We said CT scan, it is poor. So what is good? Which investigation is good? It is a diagnostic laparoscopy or exploration. Either explore the patient, do a laparotomy, or if you have facility available, go for a diagnostic laparoscopy, and if needed, go to an convert it to an open surgery. Okay, so for perforated a penetrating trauma with suspicion of hollow viscous injury, the best investigation choice is diagnostic laparoscopy. Okay, CT scan can give us excellent definition of the lesion, of the contusions, or as well as of the lacerations and the blood that is extravasating. within the capsule of the injured organ. It could be a liver or spleen or even the kidneys. So CT is very good in identifying the lesions. You can see the laceration in the left lobe of the liver here. Okay, you can see the extravasation, sorry, the contusion here. Okay, now the solid organ injuries, they are difficult to diagnose on physical examination and they may lead to significant blood loss. Grading of solid organ depends on the degree of hematoma, laceration, or avulsion. We actually classify these injuries into 6 categories depending on the degree of the hematomas or the laceration or the avulsion of the pedicle, the avulsion of the arteries and the vessels that are coming out of the hilum of that organs. The injuries, they may present late, um, leading to further difficulty in assessment and management. And the most common solid, what is the most common solid organ that is injured during any abdominal trauma, blood trauma? We have two names here, spleen and the liver. Which is the most common solid organ out of these two? What is the most common, the commonest solid organ injured during blunt abdominal trauma? It is spleen. So
Spleen.
yes, spleen, then liver, because they are uh, more prominent in the more prominent part of the abdomen and can be damaged even if there is problem related to the thorax. Both are related to the thorax and the abdomen, and any injury to the thorax or upper abdomen can cause injury to the spleen and the liver. So these are the most common involved organs, and spleen is way higher in incidence than liver in abdominal injuries. Okay, now this is the grading of the spanic injury. We divided into 6 grades depending on how much is the involvement of the spleen in the injury. If there is a subcapsular hematoma, we divide it into either a hematoma or a laceration. So grade 1 is a hematoma, which is subcapsular beneath the capsule, and there is no external injury, there is no external cutting of the capsule. So it is subcapsular hematoma, and less than 10% of the total you can say surface of the spleen is involved in it. So we call it a grade 1 injury. And if there is a laceration or a capsular tear, but that tear is just less than 1 centimeter in depth, we call it grade 1. Grade 2 is a subcapsular hematoma, which is 10 to 50% of the total surface of the spleen, or which is less than 5 centimeter in diameter. We call it grade 2. And a laceration, a capsular tear, which is 1 to 3 centimeter in depth, it is grade 2. Grade 3 is if grade 2 hematoma is a subcapsular hematoma, which is more than 50% of the surface of the spleen, or if this hematoma is ruptured and there is an intra-ruptured and there is splenic involvement, there is intraparenchymal hematoma of more than 5 centimeter, or a laceration that is more than 3 centimeter in depth, or it involves the trabecular vessels of the spleen. Grade 4 lesions are a laceration that is segmental or hilar vessels, laceration that is involving the segmental or the hilar vessels, and there is major devascularization up to 25%. Either it is involving the vessels, or it is causing some avulsion of some damage to the vessels. And grade 5 is if it is a shattered spleen. You can see in this last picture if the spleen is shattered, or there is a hilar vascular injury. Okay, previously hilar vascular injuries, they were taken as separate as grade 6, but now they are included in grade 5. So you have either the completely shattered spleen or the hilar vascular injuries. The grade 1 and 2, they can be managed conservatively, but as the grades progresses, you have to think more about the surgical management or a surgical repair, surgical control of the spleen, and we have to go for a splenectomy. For grade 1 and 2, we can offer conservative management to the patient, and even for some time for this grade 3 ruptured laceration or sorry, ruptured hematoma, we sometimes can use net made up of polypropylene to control the bleeding. But usually because of the setups difficulties, we usually go for surgery in grade 3 and onward. So the key points are hemodynamically unstable patients, they required immediate laparotomy and you have to go for a splenectomy. Non-operative management is an option in the hemodynamically stable patient only. For unstable patient, you have to go for surgery. And what should be the principle for doing a conservative management is no patient should die as a consequence of it. It should not be like this, that you are saying, I will do a non-operative management of this patient, and because of your decision, the patient is becoming unstable, patient is developing complications, and the patient dies later on. So it should not be there. The patient should be, if you're suspecting that patient is going out of your hand, go and operate the patient. Non-operative management is we do intensive monitoring, we do serial clinical examination and the hemoglobin level. In high-grade injury patients, we may require angiography and angio immobilization to improve the success rate. Patients are told to avoid contact sports for a period of 7 days. If in minor injuries, you are saying the patient to go after observing the patient, if you say the patient to go home at least for 7 days, they should not do any contact sport. If the patient becomes hemodynamically unstable or the patient is requiring multiple blood transfusions, then consider it as a failure and go for laparotomy and splenectomy. Complication of non-operative management can be failure. You have to convert it, or it could be splenic ischemia or infection and abscess formation, splenic abscess formation, or it could be chronic pain. Now, grading of the liver injuries, we grade the liver injuries into 6 categories, the same as we have done for spleen. There could be a hematoma or laceration. All these gradings are CT appearances. If CT appearance show a hematoma, which is subcapsular, less than 10% surface area of the whole liver, it is called a grade 1. And if there is a laceration which is less than 1 centimeter of the parenchymal depth, it is taken as grade 1. 10 to 50% surface area hematoma is grade 2. Or if it is going into the parenchyma and it is less than 10 centimeter in diameter, it is grade 2. And a laceration which is 1 to 3 centimeter in depth, that is taken as a grade 2 laceration. In grade 3 hematoma, more than 50% of the surface area now, and a laceration is more than 3 centimeter in depth. This is grade 3. Grade 4 is if there is a laceration that is causing parenchymal disruption, about 25% to 75% of the affected lobe, we call it grade 3, or involve 1 to 3 continuous septum. In grade 4, we have laceration, parenchymal disruption involving more than 75% of the hepatic lobe, or involves 3 continuous segments within the same lobe. Or vascular injury, especially the injury to the juxtahepatic venous injuries, like the veins which are not the main veins, the veins which are in the vicinity, like the central major hepatic veins or the retrohepatic vena cava. I'm saying not the major vein, the veins that are the part of it. If the arterial, if there is pedicle avulsions, if the hepatic artery is affected and there is the whole pedicle is avulsed, then it is grade 6 injury. But if only the veins are affected, that is a grade 5 injury. And if the patient is having other injuries like injuries of the head injuries or limb injuries, there is some limb vessel injuries, then we increase the grade of that patient also. One grade is added here. Okay, for the liver injuries, whatever is the grade, again, if the patient is stable, go for a non-operative management. If the patient is unstable, we have to go for laparotomy. We have to go for We can operate the patient, we can open the patient by rooftop in CN, we can go inside, and for the bleeding area we can go for packing. Sometimes we NG embolize that area. If needed, we can take deep liver sutures to pack or to stop the bleeding in that area. Sometimes we do balloon tamponade. Sometimes we go for hemostatic agents in that area, or if it is much out of our hand, we can go for hepatic artery ligation, though it has its severe consequences. Okay, laparotomy for a continued blood loss with hypotension, tachycardia, and decreased urine output and decreasing hematocrit. If the patient is having continuous blood loss, patient is having deranged vitals like BP is low, pulse rate is high, and patient is dehydrated, urine output is low, then you have to go this is an indication that you should go straight forward for surgery. And operative rate is about 3 to 11% is the mortality rate with multiple injuries, and about 0 to 3% when isolated. Okay. Then we sometimes we get patients with biliary tree injuries, although the incidence is very low, but it can be the presentation of some of the patients with trauma. It is about 4% incidence in total, and in if there is associated liver injury, especially the grade 4 and 5 liver injuries, the incidence of biliary tree injury is increased. How to manage it? We can go for ERCP with decompression and stenting, which can be both at the same time diagnostic as well as therapeutic. And sometimes because of the bile leakage and surrounding bile peritonitis, you have to go for washout in that area. Okay. Other complications that we can have here because of this liver and associated biliary tree injury, it could be failure of non-operative management. You have to convert for a surgical option. It could be liver ischemia, infection, and abscess, and biliary leak, myeloma, and peritonitis can also be from the damaged portal, damaged bile, small biliary ducts within the intra hepatic parenchyma. Okay. Bowel injury, it can be because of blunt trauma, it could be because of penetrating trauma like stab or gunshot, or it could be because of operative manipulation. Bowel injury can be in the form of compression, crushing of the crushing of the loop between two hard surfaces like bone and external force, causing compression of the gut between these two hard surfaces. Or it could be shearing or sudden deceleration injury, especially at the area where a loop of the bowel, a mobile loop of the bowel is converting into a immobile loop of bowel, like the areas which are pre-peritoneum and the area which is peritoneal in origin. At the junction of these two, usually there are shearing perforation or injuries. Then it could be bursting because of the increase in intra-abdominal pressure. It could be bowel injury secondary to bursting. Okay. This you can see the bowel is perforating. Sometimes it is just avulsion of the there is just superficial, or you can say incomplete perforation, or sometimes there is complete perforation or bursting of the gut contents into the abdomen. And it can be because of the trauma, especially in seat belt injury. Seat belt injury is a very uh, common cause of bowel injuries in RTS. In patients with RTS, if there are seatbelt signs, that is an indication that patient may have bowel injuries. Okay, causes can be motor vehicle accidents. 75% of the time it could be falls from height, seatbelt injuries, and penetrating trauma. It is, if unrecognized, if it is uh, um, usually what happens that when patient comes to us in emergency and we are saying the patient, okay, we do the fastest scan, there is no finding there, we say the patient is okay, we put the patient in observation, and then the patient is discharged. But sometimes these injuries, they are late to appear, and they may be missed. So it is one of the injuries that are called the missed abdominal trauma injuries, and it is one of the frequent cause of preventable death if unrecognized. Symptoms and signs are unreliable because these are masked in polytrauma and patients having head injury or major fractures or under the control of alcohol. The symptoms are not very clear; they are masked. So you have to be a high suspicion if you are suspecting or seeing such a patient with massive trauma, or patient with the seatbelt sign, or patient having penetrating injury. Uh, you have to keep your suspicion high to rule out these injuries. And rapid repeated investigations are very important to repeat investigations are very important to rule out the bowel injuries. Signs can be chymosis and abrasions. The ribs may be tender. Uh, Peritonitis can be present because of the perforation of the gut. There is tenderness and guarding, rebound and rigidity. Digital rectal examination some gives some clue also when we are doing this examination, as it may show us bogginess in the pouch of Douglas. Uh, if we are having a patient that is having blood in the area, again it is an indication that there may be some bowel injury or some bowel ischemia secondary to trauma. Hematemesis or blood in the nasogastric tube, or blood in the digital rectal exam, seeing on the digital rectal examination, again is a sign of bowel injury. So how to manage it? Management is always operative, because we cannot just leave that this perforation as such. You have to go for operate it, and if it is less than 50% of the circumference of the wall, and it is non-destructive, like it is not secondary to gunshot or a blast injury, go for a primary repair. If it is more than 50% of the circumference of the wall, or it is destructive, there are some signs showing you that the gut is not in a good state, then go for resection of that specific segment and do anastomosis. So this is all about abdominal trauma. We have discussed the the three common things that we have usually in abdominal traumas: the liver injuries, the splanchnic injuries, and injuries to the small bowel. The rest things like pancreatic injuries and renal injuries, we'll discuss them a bit in other lectures. So the things that we discussed today, these three things, and they make up about more than 70 to 80% of the abdominal traumas. So if you have any question, you can ask, then I will close the meeting. Any question? No question or any question?
Thank you, Doctor.
Okay, for tutorial, I will not take the tutorial tomorrow. Inshallah, after you finish your exam, the next week, inshallah, we will keep it. But you have to prepare it, okay? Because the same cases you will upload in your Moodle account for your continuous assessment, okay? Okay, inshallah, I'll